welcome to Pediatric Grand Rounds. Just a few announcements from me before we get started. Please remember to stay muted during the presentation. If you have questions or comments for our speaker, please use the chat with everyone feature at the bottom of your screen, and I will share those questions and comments with our speakers during the Q&A at the end of the hour. You'll be receiving an evaluation about this Grand Rounds by email in the next day or two. And please make sure to fill that out for us. It's really important for our speaker and also for our program. And finally, our planners for Grand Rounds have no relevant financial relationships to disclose. So let's get started. Our speaker today is Dr. Crystal Perez, who's an assistant professor of pediatrics at University of Washington and here at Seattle Children's. She received her MD from the University of Miami in Miami, Florida, and completed pediatric residency and neonatal perinatal medicine fellowship training at the University of North Carolina in Chapel Hill. She also completed an MPH degree at the University of North Carolina Gilling School of Global Public Health prior to joining us as faculty at the University of Washington Division of Neonatology. Her research interests are improving global newborn health and reducing disparities in health outcomes of newborns born in low-resource environments. Dr. Perez previously conceptualized and designed a study in Nicaragua to improve the care of newborns in select remote regions using Helping Babies Breathe and Essential Care for Every Baby programs paired with supportive supervision. Dr. Perez is a member of the AAP section of International Child Health. And welcome, Dr. Perez. Thank you so much.
Thank you. Good morning, everyone. And thank you all so much for coming and listening to Grand Rounds this early day. I know it's seemingly early with Zoom land, and I just really appreciate you waking up, drinking coffee with me and listening. I'm a neonatologist, as mentioned, and a global newborn health researcher, and I really feel honored to be able to use this platform to bring awareness to a significant public health topic that's really more pervasive than I had even appreciated a few years ago. So as such, I've titled this talk, Breaking the Silence, Perinatal Mood and Anxiety Disorders in the US and Abroad. In summary, with this disclosure slide, I have no conflicts of interest to disclose for the presentation, with perhaps the note that I'm also a proud mother of two beautiful and crazy boys. Click. So objectives today, my hope is to demonstrate for everyone the prevalence of perinatal mood and anxiety disorder, which if you see the abbreviation PMAD or PMAD, that is what it stands for from here on out, in various pediatric clinical settings, evaluate how PMAD affects pediatric and specifically newborn, said by the neonatologist, outcomes, and considerations and challenges to assessing PMAD both in low resource settings internationally as well as the US. Next slide. Here's the outline I plan to use to accomplish meeting those objectives. I'll begin with a personal account and explanation of how a neonatologist became keenly aware of what is arguably an adult illness, with sometimes a needed reminder to myself that addressing acute childhood illness often involves treatment of the family. I would like to define perinatal mood and anxiety disorders and why it's a national public health priority. We'll go over what are the screening recommendations and tools used to assess perinatal mood and anxiety disorders. We'll share context within the US as well as the overarching global context. And finally, I hope to use the opportunity to share some original data from Nicaragua as well as from the University of Washington, NICU, as it relates to perinatal mood and anxiety disorder. Click. My story starts with a keen interest in really pushing more than just one gear in this model. Suffice to say, socioeconomic characteristics that affect child health is complicated and really includes parent physical and mental health. All of these have influences on child health, which in turn, click, has social consequences that feed back into socioeconomic circumstances. Click. And I would be remiss if I didn't mention additional structural factors that affect all of these. You can click again. with differential effects. So differential exposures, differential vulnerabilities, and even differential consequences at every level. And you can click the last time here. So today we're really going to focus on one aspect, on the gears related to parent factors. So I think to bring this home, understanding chances are in this audience, everyone has had some personal experience with perinatal mood and anxiety disorders, though the term itself might not be familiar to everyone. Either you've experienced it personally, you know someone who's experienced that, and most certainly you have likely cared for a patient whose parents might have had symptoms of perinatal mood and anxiety disorder. My personal story starts in Nicaragua during the 2018 socio-political turmoil and violence in Managua, when my Nicaraguan colleagues were describing their concerns about the mental well-being of families, having just completed the study of essential care for every baby. While the research was placed on hold, my work in Seattle NICUs continued, and I still recall very vividly walking into a very dark NICU room with the shades pulled, despite it being the middle of a beautiful Pacific Northwest summer afternoon, finding a mom sitting quietly in the corner with her only question to me, "Tell me honestly, when is my baby going to die?" Surely there are circumstances when we attribute these questions to just being overly anxious or concerned parents. Though this mom was really scared to touch or hold her quite stable, in my opinion, baby and interactive infant, and now getting significantly less breast milk. To jump to the point for those wondering, why is this important and by what exact and tangible mechanisms does parent mental health play a role in outcomes? To name a few, parent mental health has been associated with changes in pregnancy outcomes, parent infant bonding, hospital length of stay, emergency department visits, and reduced well child check visitation, as well as influencing and with potential consequences to long-term developmental outcomes of these children. Next. Given this talk is being given by a neonatologist, we're going to focus on one specific manifestation of altered parent mental health, and that surrounds the birth of a child, termed perinatal mood and anxiety disorder. And it's really an umbrella term that encompasses parent mental illness during pregnancy and up to 1 year postpartum. It encompasses and includes depression, anxiety, as well as things like PTSD and postpartum psychosis. And classically, it has been focused on maternal experience. You can click again. Though really any parent can be diagnosed with PMAD, with ongoing literature describing various parent experiences, and that includes the paternal experience. And I will mention this again, but there's very little known still about non-gestational or non-biologic parent experiences and how it relates to this as well. Next slide. So overall, it's not surprising that, or perhaps it is surprising that perinatal mood and anxiety disorder really is a leading complication of pregnancy and childbirth. And that's including postpartum hemorrhage, preeclampsia, all of those, what we often think about as a complication of pregnancy and childbirth. Over 1 million families are affected in the United States alone. And in 2017, perinatal mood and anxiety disorder was associated with a $14 billion in societal costs. And it's understandably why the nation is calling this a public health priority. Of note, for anyone interested, knowing that there's clear mathematical calculations, when the prevalence of PMAD was varied to estimate the lowest end of the range and the highest, with the lowest end being 7% and the highest 25%. The aggregate costs were still surprisingly high in this study and ranged lowest 8.6 to a max of $30.6 billion. And I should also highlight this is just over the first 5 years of life, with likely higher costs if taken over the lifetime of the child. Next slide. So in light of the public health priority, it's understandable why there's recommendations for universal screening. The American Academy of Pediatrics recommends routine screening for perinatal mood and anxiety disorders at the 1, 2, 4, and 6-month well child checks, and that's received a United States Preventive Services Task Force Grade B recommendation, which is not a small feat. There's an additional note in the recommendations of screening parents of infants that are hospitalized or seen in the emergency department through 1 year of age. I will note that these routine screens are often missed when a premature baby remains in the NICU for some of these well child checks, or a family misses them, or a patient's in the hospital, all arguably scenarios that would place the family at even greater risk of having mental health concerns. Next slide. So what are the screening tools? I'm going to list three, both in order to kind of orient us to um, what is most common. And I mean, it looks like it's a little bit, there we go. The most commonly used and well known of the tools is the Edinburgh Postnatal Depression Scale. It's really a quite well validated screening tool among pregnant and postpartum women. And as I mentioned before, endorsed by the United States Preventive Task Force. It's a self-administered, which is also makes it quite easy to use, a 10-question screening tool with really high validity and recently reported sensitivity range from 67 to 100% and a specificity of 87% or better when using a cutoff score of 13. It's shown at the right, not that you have to read all of them, but know that each item is scored on a 4-point scale, 0 to 3, and the total scores range from 0 to 30, with the highest end being worse depression symptoms. The nice thing about this particular screening tool is that it doesn't go into common somatic symptoms such as insomnia and appetite changes, which might occur naturally in postpartum women. However, it doesn't provide a measure of severity since women with seemingly lower scores, 14 to 16, can still be experiencing major depression. Next slide. Another tool used and included here, there's various anxiety monitoring tools, but I've included the generalized anxiety depression screen. This is another well-validated and self-rated assessment tool that families or parents can fill out themselves. And while it's mostly studied among the primary care adult population, the GAD-7 has been shown to have greater accuracy and specificity to identify generalized anxiety disorder among pregnant and postpartum women. And I'll reference this again in some of my work at the University of Washington. Next slide. And finally, we'll talk about PHQ-9, so the Patient Health Questionnaire. Again, this is well validated, very simple test and self-administered to parents, 9-question survey with each of these responses 0 to 3 and a total score that can range from 0 to 27. It does have some comments about ranging from mild to minimal to severe depression, and know that a woman scoring above 9 could be suffering from moderate to severe. It was really designed to detect symptoms of major depressive disorder and is less validated among pregnant and postpartum women, but is also easy to use and has been used as well. Next slide. Just from the MPH talking, I think it's important to call out that screening tools are really not diagnostic, and it's just helpful to identify parents needing further referrals or evaluation and possibly therapy. And clearly, there are challenges to screening when there's barriers, or, for example, in low resource settings, non-existent mechanisms to refer and/or offer therapy. And I'll get to some of this as well, but I wanted to begin by calling that out. Next slide. Notably, how to operationalize the screening has its own challenges with significant variability, likely between settings, just understanding what works for each location. So each setting could have its own system. For example, which of those screening tools are used, noting that there may be others that I didn't even discuss that are pulled out, especially from the assessment of anxiety. Is there even a discussion with families on why we screen, or is it handed out as part of the intake form, expecting parents to complete that? Who provides or collects the screens and who's scoring them is an important aspect to this as well. And I'll note that it could be a secretary, it could be a nurse, it could be a doctor, it could be a social worker, psychologist. Really, any of these providers should have the means and mechanisms to distribute this, with scoring fairly simple. And finally, what are the mechanisms of referral? Hoping that there is one, and going from there. Next. So why understanding, yes, as a neonatologist, I see this with moms who have recently delivered, but I think it's also important to call out how perinatal mood and anxiety disorder screens vary across pediatric settings. So in one cohort, it was listed that primary care visit screenings had 10 to 15% of mothers screen positive using the Edinburgh postnatal depression scale. In the pediatric emergency department, screening was 27% of moms screen positive. And finally, in the NICU, 45% of mothers screen positive as they approach discharge. Next slide. So in summary, and I want to call out here that I'm focusing on women, as most data really looks at moms. So I think there's increasing acknowledgement and focus on the birth partner and the father experience. And for anyone in the audience interested in the topic, there's really plenty of opportunity, and the world is your oyster if you wanted to better understand non-gestational and non-biologic parent experiences, as I've said. So in this country, nearly 1 of 5 mothers experience mood and or anxiety disorders in the postpartum period overall. And almost 3 of 10 will screen positive in the emergency department setting. And almost 5 of 10 screen positive in the NICU as they approach discharge. So what about fathers? This is, like I alluded to, more limited data, though O'Brien and colleagues found that 1 in 10 fathers experience perinatal mood and anxiety disorder. Importantly, the most significant risk factor for depression in fathers is actually maternal depression. Also of note that paternal postpartum depression rates are lowest during the 0 to 3 month postpartum period, and really highest during the 3 to 6 month period, making recurrent screening opportunities even more important. Noting that the reality, even though there are recommendations for screening, challenges to operationalize and implement abound, and not to mention the challenges when addressing these results of the screen in many settings. Additionally, despite increasing public health awareness, many parents with PMAD symptoms remain undiagnosed and untreated. Actually, in one cohort, 1 in 5 women chose to remain silent about their symptoms, with minority populations more likely to go undetected and less likely to seek treatment. Another article suggested that as many as 50% of mothers with symptoms will not seek mental health treatment. So it's clear that there's various aspects to these barriers. I think the other important question is understanding, does screening even help? I will comment that a recent systematic review that found that screening during well-child checks as compared with care as usual had positive effect on detection, referral and treatment rates, and a reduction effect of screening on depression symptoms at follow-up. In fact, among pregnant and postpartum women, there were 6 trials that included almost 12,000 women that showed an 18 to 59% relative reduction with screening programs, or a 2.1 to 9.1 absolute reduction in the risk of depression at follow-up, being at 3 to 5 months. And this was after participation in programs that involved depression screening with or without additional treatment components. Another Dutch quasi-experimental study published in 2017 also found significantly fewer mothers were depressed at the 9-month postpartum check in the group receiving well-child check screening, with an adjusted odds ratio of 0.28 for major depression, and overall the adjusted odds ratio was 0.40 for minor and major depression. Unfortunately, there's limited literature regarding direct effects and outcomes at the child level, though there's some indirect and circumstantial evidence that we'll talk about shortly. So why the NICU? The NICU is really a sentinel place starting even before delivery, noting that there is this association between premature birth and small for gestational age newborns and antenatal maternal depression in several studies. I'll note that advancements in NICU care has really brought the chance to live to countless preterm babies, but not without cost. So understanding the inherent feeling that mothers have of guilt with the perception their bodies really failed them, and now they've delivered a preterm baby who they are now separated from. And these feelings are only exacerbated by any underlying mood disturbances. Um, the other things that can happen is there's clear differences, and that's been demonstrated in immune responses of infants born to mothers who are never versus ever depressed. And then finally, neurocognitive implications seem relatively consistent, even correcting for postnatal illness. So emotional, behavioral, cognitive, social, and language development has been demonstrated to be effective. And that's really important in the NICU when there's baseline risk. I'll also say paternal depression has also been implicated as having effects on early childhood development as well. So remembering that the literature suggests as many as 45% of mothers have PMAD and reduced opportunities for screening to boot, here are some tangible and immediate effects of PMAD that have been well described in the NICU and include impaired parent-infant bonding, increased length of stay in the NICU, as well as reduced breastfeeding. And in fact, overall, moms with postpartum depression show decreased rates of not just breastfeeding, but the breastfeeding initiation, duration, exclusivity, with many moms developing negative feelings towards breastfeeding as well. In another study by Boskirk and colleagues, they found that maternal depression was associated with poor neurodevelopmental outcomes, specifically relating to cognitive outcomes among preterm infants less than or equal to 32 weeks. And this was measured by Mental Development Index and Bayley Scale of Infant Development to assess neurodevelopmental impairment. Interestingly, in this study, it seemed to affect cognitive, though not really any motor skills, with no relationship to motor skills or even cerebral palsy. So what might be the biologic basis of some of these longer term effects? I think these are fun to talk about, and also I inserted to capture anyone who is really interested in lab research or in studying this more. Here's just a couple possibilities that seem fairly consistent as well in the literature. So the first has to do with cortisol. One of the potential mediators is neuroregulatory dysfunction, including alterations in the hypothalamic pituitary adrenal axis in children of parents with perinatal mood and anxiety disorder. There have been a number of studies that demonstrated higher infant cortisol levels with maternal depression. This maternal depression infant cortisol association has been found to be independent of delivery complications and importantly appears to be modulated by prenatal maternal psychotropic treatment. Another very interesting finding has been that maternal perinatal depression could lead to earlier brain development in children via premature myelination and synaptic pruning, which comes at the expense of extended brain plasticity. And that can affect cognitive and behavioral outcomes throughout life. So although it seems counterintuitive to think that earlier brain development sounds good, it actually can be harmful. So there's one study by Lebel et al. Published in 2016. So you could see the graphs demonstrated here on the right side. On the x-axis, you could see the Edinburgh postnatal depression scale scoring in the second trimester, reminding everyone that 13 is sort of a cutoff, and higher scores have more symptoms of depression. And then on the y-axis being cortical thickness. So in this study, they found that cortical thickness was significantly less among children with higher Edinburgh postnatal depression scale scores during pregnancy. And what's not shown, kind of in addition to these images here, is the additional significantly lower frontal cortical thickness among children whose mothers had postpartum depression. So while we say, well, okay, great, but as pediatricians, there's nothing we can do for decreased cortical thickness before birth, but there's actually also implications postnatally with postpartum depression. And I'll also just, because I think it's interesting, is that these images were taken during preschool kindergarten periods with the range of 2.6 to 5.1 years. So really a crucial time in a child's life. Next slide. So going back to my story, as a researcher interested in global newborn health as well, what is the global burden of perinatal mood and anxiety disorders? Noting that stressful life experiences, famine, violence, all are more notable in these low resource settings abroad. In fact, the estimation of perinatal mood and anxiety disorders is doubled in these settings. So comparing US estimates ranging from 10 to 21 or 25%, as compared to low resource settings that the estimation is 25 to 40%. And this is noting ongoing challenges and barriers to not only detection, but treatment, both in the US and especially those in low resource settings. Next slide. So as a pandemic has done in so many other facets of life, the COVID-19 pandemic really highlighted these concerns with mental wellness of pregnant and postpartum women, fathers, kind of parents overall. Again, knowing that a lot of this data is focused on mothers, but I would acknowledge that it really affects more than just moms. So in one survey of more than 1,000 pregnant and postpartum women, conducted sort of in the peak between May and August of 2020, they found significantly higher PMAD rates. 36% screened positive with depression, and this was compared to 15 to 20% pre-pandemic. 22% had generalized anxiety and 10% with PTSD. In another study of 900 pregnant and postpartum women around similar times between April and May, they found that 40% of women, as compared to 15% pre-pandemic, screened positive for depression, and a whopping 72% had anxiety, and that was compared to 29% pre-pandemic. So significant increase, which is intuitive in some ways, all of us experiencing the pandemic together. So I wanted to take the opportunity here as well to share some of my original research that's informed my journey that I've alluded to on this mission to support families, as well as to facilitate newborns reaching their developmental potential. Next slide. So first, we'll discuss an ongoing approach project in Nicaragua, recalling that low resource settings have higher prevalence of perinatal mood and anxiety disorder. The project is called Crianza con Amor, which translates roughly to parenting with love. Noting that the project was created and dreamed even prior to the socio-political instability in 2018, and was inspired by the drive to not only help babies survive, but to thrive, with a particular focus on parenting techniques, breastfeeding, and maternal depression as it related to early childhood development. Next slide. As one can imagine, COVID placed a damper on this, and data collections being finalized now. But no, the collected data describes certain risks and screen for early childhood development in a peri-urban community in Nicaragua. We collected demographic data, and then as far as screening, used the Ages and Stages questionnaire, as well as the PHQ-9, or the Parent Health Questionnaire 9 that I discussed earlier. The intervention hope was to intervene with education and responsive parenting,
Good morning.
nutritional support, while enabling and empowering community members. On the following slide on table 1, you can see that the details of some of the sample obtained.
Sometimes they can get a hold of families and
While mothers most frequently were the historian, and there's an equal split between married and living together with a partner. Most completed high school as well, which is great and was honestly better than I had initially expected. Next slide. In regards to developmental delays, we noticed that there was 25% of children in the cohort in the HAPA assessed using Ages and Stages questionnaire that demonstrated 2 or more developmental delays, or were at risk for 2 or more developmental delays, in meaning when I say 2 or more of the domains. Click. Of note that just as a reminder, the domains for the ASQ include communication, gross motor, fine motor, problem solving, and personal social. And our analysis revealed that children within the sample just demonstrated the greatest number of delays or borderline scores in the area of problem solving, and the smallest number of delays or borderline score in the domain of gross motor skills. Next slide. Notably, there was an abundance of depression, reminding us that we use the PHQ-9. Go ahead and click. With 55% of moms or female caretakers captured having depression, and another click. And 17% with moderate to major depression by this screen. There was not just an abundance of depression, but understandable struggles for the Nicaraguan team on what to do with these scores. As alluded to before, there was really minimal infrastructure nor referral patterns pre-existing this project. Ultimately, with sort of impromptu resources created, phone numbers handed out, and really a very personal approach between the team and these moms. Next slide. So what about here, the local NICU context, noting, and I was always told to me in my MPH training, but global health is also local health after all. Next slide. So there had been ongoing quality improvement efforts in the University of Washington NICU. This is a level 4 NICU just across the street. For those who aren't aware, this was collected as part of efforts in noting that the compliance with routine screening was fairly low. Reminder that in the NICU, our current usual practice is screening with the Edinburgh postnatal depression scale at approximately 10 days. And you can see that the baseline data on how often screening occurred at this 10-day mark was quite low. Of 21 eligible for screening, only 8 completed assessments, and this was in the periods of 2019 through January 2020, and it was less than 40%. You can see by February, and this was using an intervention of what's called psychoeducation, where a social work intern would sort of talk with the families as to why we were screening and the importance of doing that, really demonstrated quite an elevation in compliance with or without that. And you can see over 70% compliance with screening. As you can imagine, after February, data sort of ended with the COVID shutdown, but this pilot and QI work really helped inform a further project. Next slide. So as alluded to, you can imagine how COVID associated limitations really affected this, with compliance with screening again struggling and additional concerns at the forefront of the world attention, namely some virus. Meanwhile, visitation policies were changing, with usual NICU stress only on top of the stress of the global pandemic. Next slide. So in an effort to continue with ongoing QI work, as well as to improve and better capture depression and anxiety, I was able to secure funding to complete a pragmatic longitudinal cohort study that was integrated into routine clinical workflow at the University of Washington NICU. And this was from July 2020 until January 2021. The study facilitated ongoing support in obtaining screenings at 10 days per usual, and inserted again a second screen at about 2 months of age if the baby was still hospitalized, to be more in line with AAP recommendations, noting that many parents of our tiniest babies would miss this well-child check. We proactively wanted to include partners, fathers as well, and requested both the Edinburgh postnatal depression scale as well as the generalized anxiety disorder screen. Next slide. So notably, as was described throughout the world, preterm birth rate and therefore NICU admissions were very low during the study period, so the cohort was much smaller than expected. In total, we obtained 54 Edinburgh postnatal depression scale screens and 52 generalized anxiety disorder screens. Nearly 1 in 5 women screened positive at both 10 days and 2 months for postpartum depression by the screening score in our cohort, and that was far better than expected, especially noting this was collected in the midst of the pandemic, and speaks perhaps to resiliency and or not wanting to openly discuss symptoms. Additionally, 5 of 10 women screened positive for anxiety by generalized anxiety disorder, screening scores greater than or equal to 10 at the 2-month mark. Click. And that was surprising and very prevalent. Or maybe not surprising for those familiar with the experience for parents in the NICU. After analyzing demographic factors that could be associated with positive screens, we found that only gestational age was associated with positive Edinburgh postnatal depression screenings with an odds ratio of 0.81. And only antenatal depression or anxiety was associated with the positive generalized anxiety disorder screen with an odds ratio of 11. Interestingly, there were no socio-demographic factors or comorbidities that were associated with any positive screenings. And the socio-demographic factors that we did capture included education, employment, public insurance, marital status, primary language, all things that have been classically described as placing women at particularly high risk, and that was not captured. Also noting the experience of moms versus birth partners, mostly fathers that were captured in this cohort, that the scores were significantly lower, noting that the N was small as far as who we had matched couples completing these screens, though the findings that the other caregiver had significantly lower scores is consistent with existing literature. And recall, just as a tincture, that there is some evidence that paternal depression peaks somewhere closer to 3 to 6 months. So perhaps not wholeheartedly surprising and would be important to continue following. Next slide. I thought it was important as well to understand the evolution of screening scores. Although there's no significant difference, I think it's important to note as a reassuring 10-day score does not necessarily predict normal scores at 2 months. And so looking at the Edinburgh postnatal depression scale, you can see some of the quite low scores were on an upward trajectory, and reassuringly that the very high scores did improve with time. And so I think that highlights the importance of repeat screening. Visually on the generalized anxiety disorder screen, you could see this upward slope for many of those anxiety scores, though because it was a small n, it did not reach statistical significance. Next slide. So what are the next steps in thinking through what to do next? There's plenty of unanswered questions. Next slide. I think first understanding follow-up, knowing that screening would then result in referrals for therapy and further evaluation by a licensed specialist. And that could include cognitive behavioral therapy and or medications, and understanding that link between screenings and that referral is important. Also addressing the challenges in low resource settings to screen without any clear follow-up or treatment plan is another area of interest. Next slide. So the University of Washington NICU with myself and Rachel Morin have been funded to create durable and sustainable educational materials in order to optimize training of all NICU providers and pairing that with parent education. Understanding that it's relying on one social worker for an entire unit versus all of us providers similar in the well child check arena that have a lot of face-to-face with families. I think we should feel empowered and educated enough to improve screening practices. The hope is that would improve not only screening, but referrals, and then reduce the burden of illness in the NICU with regards to perinatal mood and anxiety disorders. Next. As far as Nicaragua, there's ongoing analysis of the data we've collected with further collection in rural communities of Nicaragua, in La Rax, assessing the role parenting and maternal depression play on early childhood development. And this is a beautiful baby there, and that's them collecting some data. Seems quite happy. As far as opportunities realized, I think to call out some successful practices, peer groups really have shown promise And whether we like it or not as well, mobile technology is prevalent, and a large number of interventions have focused on reaching families this way. There's also NICU models with psychology staff to proactively support these families, knowing how high the burden of perinatal mood and anxiety disorder is within. Unfortunately, that's not the most common model, but I think is really important. And again, as a call out, as a pertinent example of another intervention being currently investigated, is a pilot led by NICU fellow Sarah Netches that I look forward to hearing the results from, with her feasibility data completed, called Yoga in the NICU, recruiting soon. So I think my hope is that will be a huge success. So what we do in the NICU is just one small gear in the moving life story of a child. I do hope after my discussion that we recognize how much interplay there really is between acute child illness and home environment on the ultimate outcomes of all of our patients. I think even admitting to myself, for me, it's easy to forget about these other factors if it's not proactively placed at the forefront of my mind. But the reality is we really can't move one gear if the others don't move. And so in my experience as a neonatologist, admittedly an ICU, an intensivist, parent well-being really has been highlighted as an additional variable modulating the long-term outcomes of the highest risk newborns. And this is both in low resource settings as well as domestically. Next slide. So in summary, the treatment of acute neonatal illness is only one paragraph, maybe even just a sentence, in the chapter of newborn health. Perinatal mood and anxiety disorder is a leading complication of pregnancy and childbirth that comes at high societal costs and has lasting implications on child health. And then finally, we don't know what we don't ask. And that screening and family-centered care is really crucial. And there's a lot of work needed on how best to support families, both domestically and abroad. Next slide. So I'll open to questions. This was a photo, again, taken during the Nicaraguan study. This one was sharing books with the children. Interestingly, the books that young children often had was only the older siblings' school books. So you can there's clear excitement with an age-appropriate book handed out. And I also did want to give a shout out to Dr. Pham, who co-authored a Pediatrics in Review article on this topic in 2017. I think she is currently with us as an adolescent medicine doc now.
Thank you so much. We'll open it up for questions. There were some questions in the chat during the presentation, so I'll ask them and I'll kind of tell you what time they came through so that we can figure out what they are referring to. But from Dr. Zhang, are there validated translations of any of the tools that you mentioned kind of in the first third of your talk?
Yeah, I think all of them, as mentioned, definitely have Spanish and have been validated. Most of them have also been validated outside of the US. And there's been studies looking at that as far as the correlation. Interesting, there's maybe answering more than that, but there's also attempts at correlating Edinburgh postnatal depression scale scores with the PHQ-9 and understanding discrepancies between those as well.
Thank you. And from Tori Lowe, thank you so much for pointing out the gender perspective on this research and room for progress here. There are so many birthing parents who don't identify as moms or women who are maybe not represented. This info is so valuable for everyone. And then along similar lines from Dr. Shaquita Bell, I really appreciate Dr. Perez's attention to the vast diversity in parental identities and the importance of including them in this work. So thank you for that. And I'll be quiet for a minute and wait to see if others are typing questions or comments. And also, if you're listening and you feel inspired to unmute yourself, you can feel free to do that and ask a question with your actual voice. We have to get back used to doing that because we're hoping to go back live in January.
Well, Suzanne and Crystal. I don't have an ability to type, so I will ask it verbally. Thank you so much, Crystal, for your work. I'm curious what you think, as you do this work, what do you think we can do to help prevent, uh, this kind of anxiety and depression in moms? Is there anything we can do to prevent it up front, before we have to screen and find it?
Yeah, that's been sort of at the forefront, and talking to Amrita as well. I think in my mind, I don't know. I think what I would initially begin with is the ability to talk about what's been so taboo, or doesn't feel comfortable talking about it. I think once we start, and those feelings can be worked through, maybe that would be a starting point. Moms at least in the NICU, they feel like they need to be so strong for their baby. They're doing a million and one things. Eating is not at the forefront. So I think the first step in my mind, I don't know if it's true. It's not been super clear on studies, but would just be talking about it, and having parent education, normalizing in some ways that even if you have this, it doesn't mean. And I think even the terminology, right, disorder is really disheartening. So I think that would be the first step. Um, Evidence is sort of mixed whether screening alone helps, but to me, that's sort of what it suggests is educating parents, being able to, especially providers who have a lot of face to face, like the primary care pediatrician, demonstrating an investment in not just the baby but the family. I think would go a really long way.
Great, thank you.
Thank you. I'll wait a few minutes for anyone else to either type or unmute.
I don't know if I'm allowed to ask questions of the audience, or if someone is in the any emergency department specialists are out there. I was just curious as to the practice in that setting, what's done at Seattle Children's. While we wait, if anyone's brave enough to answer,
I'll give,
I can address.
I can give I don't think much is done in the emergency department busy setting, but I'll give others a chance to answer that before I take over that. But then in the meantime, while we're thinking about that answer from Dr. Jackson, given the prevalence of PMAD, what FTE should a large NICU have for our psychologists?
That's a great question. It maybe sounds sarcastic, but it's not. I think any FTE above 0, which is currently allotted, would be good. What we did know, and it probably depends very much on the census and probably the baseline prevalence of mood and anxiety disorder in that unit. But there's countless models, and if that's something of interest, I can certainly reach out and understand what's been done elsewhere. Even 0.1 FTE, I'll say, from the collection of data during these QI efforts, was sufficient for someone coming in for several hours twice a week and meeting with families. So it may not need to be an exorbitant amount, but I think it's a starting point, and you can build on that. But I think the steepest curve is getting a NICU psychologist in.
Thank you. And how often should parent peer groups meet for PMAD?
Yeah, I think there's lots of peer group models. One that comes to mind in Seattle, and there's some resources listed on the website other parents may know, but there's a PEPS kind of peer group, and I think some of that all depends on what these groups need. And there may be certain peer groups that want to meet very frequently, and others that need less. So at the end of the day, I think gearing it towards and making it very personal is important. Clearly, once every 6 months won't be sufficient, but they often happen more often than we think, because there's true value and a sense of community and support for families.
Thank you. And from Dr. Zhang, I'm sorry if I missed this, but are there inequities in who is screened?
Um, yes, there's been some demonstration, and it's hard. I think it's a little bit mixed as well in both maybe comfort in discussing these with various groups. There's also probably in some level discomfort in talking about it within the groups. And so knowing that generally speaking, it's already taboo, and who's most likely to turn in a screen will be is often less commonly minority populations. And then culturally too, even thinking in Nicaragua, there's sort of this stigma associated with this admission of depression, and understanding, mom's the one taking care of the babies, that they don't have time to go seek help. And so there are clearly inequities, not only just in screening, but also attention, getting treatment, and completing those referrals.
Thank you. And do you think the lack of evidence that SES influences mood disorders in your study is due to the low N or something else? Similar question.
Yeah, it can definitely, I think, be partly in part at least explained by the low N, or the low total cohort captured in that time period. I think the distribution, especially in Seattle, Seattle cohort compared to, let's say, North Carolina, where I train, cohort is also very different, and understanding how that plays a role is also important. So in regards to setting, and what that feels like, and how different you might feel. So I think all of that is important.
In an ambulatory setting after the ICU care, how can we help support the families?
Yeah, that's a great question, Carol, too. And I think alluding back to when Leslie was asking, I think first and foremost is acknowledging that families may need support. I think arguably that the ambulatory care setting is isn't untapped. I don't want to say untapped, but it is a very good opportunity, especially for providers that really know these families, to begin screening, to begin honest conversations about this, trying to normalize it, and it knowing that it's very common. So I think that would be a starting point in supporting them, screening them, talking to them about these issues.
Thank you. And bringing it around again, you had a question for us about emergency care. And while I don't think there's anything official in place for screening, we do know that these families are under high stress, and especially high stress during the emergency visit for most families. So can you just comment on what you think we should be doing in the ED, like how we can improve?
Yeah, I think again, system change is hard, but I do think it's not just the acute stress of the ER, but there's been some demonstration that parents that frequently visit the ED, and maybe less frequently go to well child checks, are notably parents that are more likely to have perinatal mood and anxiety disorder. So I don't know if possible it'd be a fascinating, if anyone's interested, to collaborate on such a project, but it'd be, I think, a fairly low hanging fruit to do a QI, and making sure we screen any child entering at 1 year or less per AAP recommendations, just to screen families for that. I think it's always better to talk to families about what we're asking them to fill out before just handing them paper. But yeah, I think that would be a really good starting point.
That's a great idea. Okay, thank you. A couple more comments and questions have come in. Curious to hear your thoughts on the impact of individual patient rooms has had on parental experience in the NICU. There are clear positives for privacy, but some who have experienced both express loss of community and support provided by access to other families in pods. An interesting fallout of redesign. Wow.
Yes, it's a mixed. It's mixed. I think what I tell the residents too, and maybe they remember, is that nothing is fully benign. That there's consequences to everything. I think there's a lot of benefits to private rooms, but I do think the social, as far as the social support, might be less. I think there's possibilities of overcoming those risks, and but there needs to be proactive kind of arrangement and opportunities for families to collect and talk to each other. But totally agree, noting that you know, there's even a family currently that knows another family and they just discovered each other after 2 weeks, knowing there's private rooms. So I'm hopeful that that interaction will be beneficial for that particular family.
Oh, wow. Thank you. What is the involvement of the public health nurse home visits in following up with screening and improvement if therapy has been initiated when the babies go home?
I might need clarification on the question, Eileen. So public health nurse home visits, I think in some ways are helpful in a frequent follow-up form. It's always nice to have some support. No baby goes home with a instruction book. So even myself as a pediatrician, I think that would be helpful. Um, as far as following up with screening and improvement, I think if you're alluding to the opportunity for the public health nurse to be kind of a supplement to let's say therapy because mom screened positive when she delivered. I think that that's certainly really beneficial. There does need to be some interval time and assessing of improvement, but again, I think what has been clear even through questions is just the sense of support and acknowledgement of those things by a public health nurse home or anyone frankly that knows a family well probably goes a long way.
Thank you. And thank you so much for discussing this very important topic. I'm thinking about how parental mental health affects child development and how this could lead to moms/parents feeling additional pressure to be okay when they are having challenges and or being blamed for child development issues. Any thoughts on that?
Yeah, it's like the perpetual guilt. There's always something to be guilty for, and so I think you are totally right. And in some ways, I wanted to insert. I'm not saying that there's a one-to-one that because moms have depression, they're going to have developmental issues. But I think maybe in the lens of understanding this is why it's important, and there seems to be modulation with therapy, and that you don't have to be okay. So it's very hard and a tricky game, and how to phrase that and talk with families about the importance is challenging, and that there's a being a mom, it's like a perpetual guilt-inducing activity, regardless of end result. So I totally understand. I don't know if those thoughts are helpful, but yeah, I'm there. I get it.
That's a great answer. Yeah, there's guilt is everywhere. Thank you. And then hopefully a follow-up comment. Hopefully this evidence will lead to more funding.
Hopefully, yes. I was hoping with some of the biologic plausibility is more palatable to those funders that need more tangible things. But it's classically, and this is part of the problem too, a pretty quote touchy-feely topic, but has real life implications. So
That's
hopefully,
really important.
Liz.
All right. Well, thank you so much, everybody. I think we are just about out of time. Great ideas for future work, including the emergency department. I know there are a lot of people who would be interested in partnering with you there, so we can talk offline about that. But I really appreciate all our participants for being here and the really, really good thought-provoking questions, and especially you, Dr. Perez, for your involvement in this really important work and this fantastic talk. So thanks, everyone, and we'll see you all next week. And thank you, Dr. Perez. Have a good day.